Welcome back. Let's go through the fun stuff today. So, drug development and adverse reactions. So, of course, animal testing is necessary. You can't really get away with that because it has to study the acute toxicity, subacute toxicity, and chronic toxicity. And it's not really ethical to do it in humans. So, these are important because it's going to grade the pharmacological effects on different systems, and it's going to also grade for reproductive toxicity. Mutagenesis, you use the Ames test, which is a strain of salmonella grown in a histidine-lacking culture. So if it grows, salmonella has mutated to survive without the histidine, and that's really important to use to screen chemicals. The dominant lethal tests are when male animals are exposed before mating to see if the trait is dominant, and if the abnormal embryos have the mutation. So the drug development steps, there's a bunch of them: modification, identification, rearranging of the molecular structure in order to make the lead compound. So the lead compound is the thing that's tested. And then once it's tested, it's submitted as a new drug application to the FDA. If the permission is granted, you go through the clinical trials, and then there's going to be, of course, like the actual new drug application to the FDA. So this is the investigational new drug. Sorry, that wasn't clear. So there's you submit it like 3 times. So first you submit the investigational new drug, then the actual new drug, and then if it's permitted, it goes to marketing, and then it goes to the post-marketing surveillance, also known as like pharmacovigilance. So phase 1 always tests for the safety and determines a safe and tolerated dose. It also determines the pharmacokinetic properties. It's in a small group first, and then in phase 2 is going to be the randomized controlled trials, and it establishes or it compares with the established drugs and evaluates more toxic ranges. Is when a bigger group is tested. Phase 3 is going to be the large scale randomized trial, so it's going to be like the double blind crossover, the placebo controlled studies. And phase 4 is going to be a huge sample because it's already reached market. So genetics play a huge role in the way our bodies metabolize drugs. So some people have the allergies to drugs, and it could be due to just mutant genes, genetic polymorphism. But usually the genetic polymorphism is what affects our metabolism of drugs. So beta blockers are going to be less effective in people who are not just African American, but Black, and then people of Native American descent. But people of Asian descent are going to be twice as sensitive. So CYP2D6, this is going to be a gain of function mutation, and this is when the patient metabolizes the codeine too fast, and it leads to respiratory depression. CYP2C19 is going to be a loss of function mutation, so there's less metabolism and then increased clotting of certain drugs. DPD or 5-fluorouracil gain of function mutation is going to be increased toxicity. CYP2C9 is the inactivation of S-warfarin. So VKORC1 is a loss of function mutation, and that's going to lead to the warfarin toxicity. So UFT1A1 is a loss of function, and G6P deficiency is a loss of function. Glutathione is reduced, leads to hemolysis. So these are the important ones because these are the most common mutations. So to continue, pseudocholine esterase mutations, usually in an atypical PE, the effects are going to be too long, and it leads to respiratory paralysis. The hydroxylase polymorphism leads to a phenytoin toxicity. Acylator status. So people of Eskimo or Japanese descent are rapid acylators, and it can lead to hepatotoxicity, while people of Egyptian or Mediterranean Jewish descent are slow acetylators, and they can lead to sensory neuropathy. TPMT, loss of function, it's going to be increased toxicity, and this is a mnemonic right here, see Wi-Fi password SCO. So codeine, warfarin, isoniazide, fluorouracil, irinotecan, phenytoin, azathioprine, succinylcholine, clopidogrel, and oxygen species. These are the ones that are affected by these polymorphisms. So the HLA polymorphism is also known as Stevens-Johnson syndrome, and it causes all this topical epidermal necrosis along with ecchymosis, and it's a hypersensitive reaction to abacavir, which is an anti-HIV drug. Transporters can be an organic anion transporter 1B1 that transports drugs and endogenous compounds from the blood into the hepatocytes. A reduced function of this transporter will lead to simvastatin toxicity and increase risk of a skeletal muscle myopathy. P-glycoprotein, P-glycoprotein transporter mutation is a multi-drug resistance transporter 1, and it expels cytotoxic drug from resistant cancer cells. So this is the one that's going to save our cells from the cytotoxic drugs, and it's encoded by the ABCB1 gene. Okay, so adverse drug reactions. An adverse drug effect is any undesirable or unintended consequences of drug administration. It could be, fast or late, and it can be trivial or serious. And the adverse drug reaction is any noxious effect that is due to a drug that occurs at normal doses. So the difference between adverse drug reaction and adverse drug effect is not necessarily bad. For an example, one of the medications out there for insulin right now is one of the adverse drug effects is weight loss. So somebody who's struggling with type 2 diabetes, usually they're overweight. This is not necessarily a bad side effect. But adverse drug reaction, sort of like too much warfarin will lead to increased bleeding. That's an adverse drug reaction. So it's more common in multi-drug therapy, and in the elderly because they have a lower ability to metabolize and excrete the drugs. And adverse drug event is the most serious because hospitalization is needed. Events have to be reported to the FDA. So in a minor drug reaction, you can just modify the dose. It's manageable. Moderate, it requires of course, change in therapy, change in dosage, and it prolongs a hospital stay by at least 1 day. Severe can cause permanent damage and requires intense medical treatment. Lethal, of course, contributes to the death of the patient. So there are a couple probability scales that people use, and a severity scale to drug the efficacies and the safety and the tolerance of a drug. So side effects occurs at the therapeutic dose. Secondary effect are the indirect consequences, and toxic effects, of course, are serious. Intolerance is going to be just more sensitivity to a drug, And allergic could be from a rash, or it can like be as severe as anaphylaxis. Okay, so drug allergies have two different types, so humoral and a cell-mediated response. Type 1 is going to be humoral, IgE is going to be involved, anaphylactic or immediate hypersensitivity, pretty serious. Type 2 is a cytolytic effect, IgM, IgG, and the complement system is going to be activated. Type 3 is going to be like the retarded effect, Arthur's reactions, where IgG, AG, and AB complexes bind the complement proteins, precipitation on the vascular endothelium, and the cell-mediated one is going to be type 4. It's the delayed hypersensitivity reaction, where the T cells, of course, will have the receptors for the antigens and the lymphokines. Photosensitivity is where, like, the skin is sensitized to UV radiation. Phototoxic, on the other hand, is going to cause just blistering, more severe tissue damage. Photoallergic is just it's going to cause a type 3 reaction, cytolytic reaction, so a cell-mediated, or type 4, sorry, because it's cell-mediated immune response. So physical dependence is going to be an altered physiological state made by long-term drug use, which needs the continued presence of the drug to maintain the equilibrium. Neuroadaptation, basically, it's both a psychological and physiological adaptation to the drug, and it is, withdrawal symptoms occurs if you take it away. It's a required feature for physical dependence diagnosis. Stimulant drugs will produce no physical dependence, surprisingly enough, but it has a very severe psychological dependence. Rebound effect is sometimes when you take away not the drug or withdraw it, the body will overcompensate. So if you take away a certain blood pressure medication, I'm not sure which one it is, but the blood pressure comes back and is higher than ever, and then you need even more of the drug to bring it down. So there's several reactions to withdrawal. The acute adrenal insufficiency, of course, when you stop the corticosteroids, and it causes the severe hypertension, restlessness, sympathetic overactivity when you stop the clonidine. And if you stop beta blockers, it's going to worsen the chest pain. It's going to increase the risk of a heart attack. If you stop anti-epileptics, of course, there's going to be an increase in seizures. And most drugs need the gradual tapering. You can't just take it away and quit cold turkey. Teratogenicity, of course, these are the most important ones you have to know. Remember the thalidomide disaster, where there's the stunting of the limbs. Can be caused by alcohol abuse, along with these medication. And it's going to be risk versus benefits, especially when it has to do with something bipolar medication or blood thinners. The most dangerous time, remember from embryology and development, is the first trimester, specifically the weeks 3 and 8, because that's organogenesis. The oxidation of drugs will make the reactive intermediates, and that will change the genes, cause structural changes in the chromosome, and can lead to mutagenicity. The covalent interactions with the DNA will lead to the mutations, and that can be heritable. So that is not good. Okay, so here are some interesting drugs that you should know, especially like the organophosphates. You need an antidote of atropine. Let's see, acetaminophen. You need N-acetylcysteine. Beta blockers, glucagon, of course. Carbon monoxide, 100% oxygen to compete. let's see, aspirin, you need sodium bicarbonate to alkalinize the urine to increase excretion. Remember, this is the like one notable exception, because usually you want to acidify the urine to excrete other drugs. And so, same with the tricyclic antidepressants, you want to give sodium bicarb. Warfarin, you want to give vitamin K, and fresh flows in plasma together. Copper, arsenic, gold, or heavy metals, so you give penicillamine. Mercury, you give dimercaprol, so BAL, and Suxamar, either or. Dimercaprol is given like IM or IV. And let's see, methemoglobin, you give methylene blue along with vitamin C. Neostigmine, physostigmine, you give atropine. And for iron, you give these chelators, the deferoxamine and deferoxarox. We'll go over that the next lecture, but these are the ones you want to know. So that's it for now. Thank you for your attention, and good luck studying.